Thank you, Dr. Chitra ma'am and ARC for giving me this wonderful opportunity to present in this platform. So I'll be debating against intravitreal steroids along with cataract surgery. I think my opponent took the topic differently. So it is whether giving intravitreal steroids along with cataract surgery or without intravitreal steroids. So it's not about giving periocular intravitreal steroids. So cataract forms around 40% of visual loss in cases of uveitis, and the visual outcome depends upon the type of uveitis. So it's not the visual outcome, it differs for anterior, intermediate, and posterior uveitis. The management of cataract surgery has to be individualized depending upon the type of uveitis. So the indications of cataract surgery would be 1, phacoantigenic uveitis, 2, in a case of quiescent eye, so visually significant cataract, or 3, in cases of posterior uveitis, if the cataract hampers fundus assessment, and 4th, in cases of combined phaco-vitrectomy, if cataract is causing media haze. So when do we do cataract surgery? So we should need at least 2 or 3 months of quiescence period before taking the patient for cataract surgery. So it gives good visual outcome and it reduces the post-operative inflammation and other complications. The standard preoperative inflammatory prophylaxis of oral steroids works very well, and it should be given 1 week prior to the surgery. Following cataract surgery, it should be tapered for a period of 1 month. And in cases of uveitic macular edema, if it is pre-existing, it has to be treated with a pre-operative intravitreal steroids rather than combining intravitreal steroids along with cataract surgery. The MUST trial has studied the prophylaxis of intravitreal steroids versus systemic steroids in preventing uveitic macular edema, and there was no any statistical significant difference between these two groups. So if you look at this tabular column, this is the global variation and pattern changes in epidemiology of uveitis published by Dr. Ratnam et al. In 2007. And the idiopathy causes almost 44.6%, out of which anterior idiopathic uveitis almost 25.6%. So most of these cases, if you control the preoperative inflammation, you may not require intravitreal steroids during cataract surgery. And infectious causes around 30.5% of cases. So most of these cases might require antibacterial or antiviral prophylaxis rather than intravitreal steroids along with cataract surgery. Only non-infectious group compromises 24.9%. We'll be discussing about that. So coming to glaucoma, so around 20 to 40% of uveitis patients develop glaucoma. Either it is open angle or closed angle. Open angle could be due to the inflammation which causes damage to the trabecular meshwork, or it is due to steroid responder because of the long-term use of steroids, or it could be due to closed angle because of pupillary block or peripheral anterior steinicate, or in cases of ciliary body rotation in VKH. So definitely giving intravitreal steroids it should be cautious and it should be avoided, rather than we can consider systemic immunomodulation rather than giving intravitreal steroids. So the safety profile of dexamethasone implant has been studied in this MEAT group. So if you look at this tabular column, the increased IOP is the second most adverse effect. And if you look at this tabular column, so in any form of systemic steroids, even in any form of disease, if you have been given, the IOP rise is different. Definitely it is a concern and it has to be considered. So in cases of non-infectious posterior uveitis, whether it is isolated or if it is associated with a systemic autoimmune disease like SLE, systemic vasculitis, Behçet's, sarcoids, or multiple sclerosis, definitely intravitreal steroids alone is not going to work. If you have to control the inflammation, you have to control the inflammation of eye as well as systemic disease. Only then you can prevent the recurrence. So for which definitely you need a systemic immunomodulatory therapy, either in the form of steroids or immunosuppressive therapy. As we all know that systemic steroids long-term will cause a lot of adverse effects. So we have immunosuppressive therapy. We have a different groups of immunosuppressive therapy ranging from antimetabolites, alkylating agents, and T-cell inhibitors. Commonly, we use azathioprine, methotrexate, mycophenolate, and cyclosporine. So we can monitor the side effect of these drugs regularly at regular intervals by doing all the necessary blood investigations. So these are safer group of drugs. By combining this immunomodulatory group of therapy, we can control the inflammation of systemic as well as ocular, and we can prevent recurrence. So we can consider another alternative technology called supracoridal injection, where it delivers targeted delivery to the respective structures. In PEACH trial, they have studied that there is a low incidence of IOP rise, and these drugs stay for at least for a period of 3 months. So another concern is economic burden. So in this study published in British Journal of Ophthalmology, you can see that the group which have uveitic macular edema and those group which does not have uveitic macular edema, the cost burden is definitely statistically significant. And in another study, the economic burden has been reviewed in non-infectious uveitis of posterior segment, where the cumulative cost of systemic therapy over 3 years for a patient with unilateral and bilateral is definitely less than those the patient who received implant therapy. So another considering factor is complications of intravitreal injections. As we all know that OSUDAs can migrate into anterior chamber, especially in cases of complicated cataract surgery when they develop PCR. And the patient can again has IOP rise. IVT again can migrate into anterior chamber, can cause sterile endophthalmitis. In case of PCR, it can cause again endophthalmitis. And so we should optimize the patient of a cataract in cases of complicated cataract in uveitis. So we should have a proper preoperative optimization, intraoperative considerations, and postoperative management. So when is the best time for intravitreal? If at all, if we prefer intravitreal steroids, whether to give preoperative, postoperative, or intraoperative. So definitely preoperative, there is a pre-existing macular edema. It has to be treated, and then the patient has to be taken for cataract surgery. And for postoperatively, if the patient is developing macular edema, definitely it has to be considered postoperatively rather than giving intraoperative intraocular steroids. So to conclude, so definitely intravitreal steroids along with cataract surgery cannot be considered in the following conditions like infectious uveitis, those patients who are at glaucoma, and those who develop PCR intraoperatively, and those who are having pre-existing exudative retinal detachment, and those quiescent uveitis who are already on systemic immunosuppression therapy did not require intraoperative intraocular steroids. Thank you.
Thank you, Thenarasun, and thanks a lot, Ketan. Both your talks were very good. So I'll take one question and then leave the court to Srinivas. So I'm going to ask this question to Dr. Avinash. What would be, if you are decided to give an intraocular, along with the IOL surgery steroids, would you prefer giving tripod or would you prefer giving Osidex? And would you believe in giving before or during or few weeks after the surgery?
Yeah, thank you for that question. So there is no one answer for it, but the indications of whether to use triamcinolone or dexamethasone implant would primarily rely on socioeconomic considerations in my practice. So if that be the case, I would prefer dexamethasone implant over triamcinolone for two reasons. Number one is it doesn't cause so much of vitreous opacities as sometimes it can, triamcinolone can cause. So that's one of the major reasons. And for some reason, the intraocular pressure rise has not been as steep as sometimes it can happen in triamcinolone, especially when there is an anterior injection of triamcinolone, which can happen in practice with few individuals. And those are two reasons why I prefer dexamethasone. And the second question was whether preoperative, postoperative injection of co-administration of deposteroid. So if the intraocular inflammation has to be under control preoperatively, and then only when we take up for surgery. But in circumstances where intraocular inflammation has been controlled adequately, so we prefer to go in and inject deposteroids during surgery. So if it's not controlled preoperatively, we try to control the inflammation preoperatively if there is a dire need to do cataract surgery. So, and during the surgery, we again prefer methylprednisolone before the surgery, and at the end of the surgery, if the inflammation is still overwhelming, I would suggest the cataract surgeons to go ahead with the deposteroid into the eye, and even sometimes top it up with intracameral dexamethasone as well.
Thank you very much, Dr.
Can I make a point, Dr. Chitra?
Yes,
yes, madam. Yes.
See, My experience with the IV intravitreal triamcinolone in India is that these drugs are not very safe, not standardized. They are not refrigerated. And so the risk of contaminated drugs and infection is very high apart from inflammation. So I would say that they are even unsafe actually. And I have given up since 2018, having burned my hands with these. So I would say even keeping safety in mind, Dex implant would be much better than trying
but in Aravind, we have preservative-free steroid disposed in small amounts in a laminar hood. According to the procedure, you can buy that. It is very, very safe and very less expensive.
Yeah, that is a different story. But what everybody has access to is not that. Everybody has access to different kinds of triamcinolone acetonides, which are not standardized, and not even, I think the sterility they keep in mind is not for intraocular use even, because that's used for intra-articular injections, intravertebral injections. So that is the kind of things they are used for. And here it is.
No, I think, Dr. Goel, you have a parallel experience of people who have to procure from which company they procure. I think those discussions can happen. But over a period of time, when we see that in the product what has been procured and for over 15, 20 years, it has not caused a major dent in day-to-day practice. And that's what even you are implying. If it has caused problem to you, then you might change your practice. But for rest, I guess, it has not caused any major change in terms of contamination. So I think we can still go ahead and prefer to use, because there are, or not all can afford an Ozurdex implant in the eye.
Only in vitrectomized eye, Ozurdex is better.
Yes, Balu sir. Bala sir.
Sir, I have a small additional point to make. In my practice, the definite indication to give intraocular steroids in cases where there is 360-degree posterior synechia, though those cases have a higher tendency to develop severe post-op inflammation, especially in non-infectious scenarios. In the Indian scenario, a lot of infectious uveitis are common. We have to be very selective in choosing a non-infectious uveitis, and where we anticipate severe post-op inflammation, where 360 posterior synechia, we mandatorily do a peripheral iridotomy as well as supplement with periocular steroids.
I think Bala sir asked my question, he answered it. When the patient, of course, in the non-infectious uveitis setup, he has a posterior synechia 360 degree. He has a PSC with a complicated cataract, and I plan him for the surgery. Now, if he is not a diabetic, does it make sense to start him with preoperative oral steroids at least few days before, and then take him up for the surgery and slowly taper him out? So if it makes sense, then well. Then second point is, what if he's a diabetic? So again, you have to ask for the treating physician to alter his dose of insulin, or you give a pre-op Dex. But most of the times these patients are not affordable. Then what is the thing? How can we handle it? Should we go in for the IVTA, or just ask the physician that oral steroid works better in these cases? And
periocular steroid
or posterior subtenon steroid. You should give
posterior subtenon steroid.
A few days before.
3 days before.
Yeah.
And my last question is, in case of one we did not discuss is about the ethambutol toxicity, which is also coming up very high. Is there any recent change in the treatment regime of ATT?
Yeah, they've changed it.
And have we seen that the ethambutol toxicity levels have gone up? And how frequently we have to monitor, because we see most of the cases on ATT, and how early we have to pick up? What are the early signs that we need to know about this ethambutol toxicity? Yes, Ratina madam.
It is becoming a big problem.
Actually, the government has changed the regimen. Originally, it was ethambutol only for 2 months. Now, ethambutol is given for 6 months in systemic tuberculosis. When we refer the patient for free drug in government hospital, even for ocular tuberculosis, the same way they give 6 months ethambutol. That is the reason we see more number of ethambutol toxicity now. So what we do is, we don't ask the government to give. In such patients where we expect ethambutol toxicity, we stick on to original protocol of 2 months 4 drugs and 2 drugs 4 months. Without ethambutol only for 2 months.
And Srinivas, to answer your query about the earliest sign, if at all there is any doubt from any reason, or even without doubt, if you want to be sure, I think VP is the best way. VP, because we have, we can miss.
How frequently we can keep doing VP, madam?
Maybe every 2-3 months, 3 months.
You can do a visual field.
Visual field and all are very not so sensitive. Color vision, visual field, even visual acuity can be very misguiding. But VP is a very objective test, and which picks up as the first. In fact, I have had patients where we could not pick up. The patient was symptomatic. Everything on our examination was normal. Color vision, fields. It is only on VP it was subnormal, and based on that, we were able to stop the treatment.
Sudarshan sir, your views?
We actually follow with fields and color vision. We were actually taught as interns to check the bottle cover of the ATT drugs, which had like red and green and different colors. So the patients, when they give the drugs in the TB center, they would be asked to check the cover of the bottle to see if they are continuously able to see the color of the bottle, and then come back to us if they find any difference in contrast.
Dr. Sudarshan, I had a patient on ATT. She was complaining of vision drop. I said it may be due to cataract. Vision could be improved to 6/6. Color vision, fields, everything normal. And I allowed them to continue. Despite their suspicions, I allowed them to continue the ATT. And after 2 weeks, they sent me the VEP report. Of course, I had said that you can do a VEP if you want. And they sent me the report. It was subnormal. And patient's vision by that time had dropped to 6/24. And
logistically, I think VP probably picks up early, but is logistically doing it 2 months, you actually finish off the Ethambutol course itself in 2 months.
Yeah, whatever.
Every 2 to 3 months you do.
No, periodicity we can discuss, but my point is that is the best, single best.
Probably. No, actually, I was talking to Kalpana the other day, and like and some other pulmonologists here. So they were telling that it is not that if you are so worried about it, they can probably substitute another quinolone or anything other than ethambutol. So levofloxacin is one drug which they use it. So initially ethambutol came into play after the streptomycin was removed because of the DOTS therapy. So now that now our pulmonologists actually, when we are in doubt, they replace ethambutol with levofloxacin, especially when you have a disc edema with serpiginous or macular choroiditis, a disc involvement. So you already have a compromised disc, then you would probably not use a drug which will again compromise it more. So you can probably substitute with levofloxacin.
Okay.
Private sector, the physicians agree and they give the prescription, but in government sector is very difficult. Recently, we have done the survey and we are working on that to statistical analysis and try to publish it and convince the government to change the policy based on the toxicity report from the experts. So we are working on the manuscript now.
I've got a VIP patient of serpiginous choroiditis, got healed and ethambutol toxicity lost vision.
Yeah, I have had patients of uveitis where I advised anti-TB therapy for the uveitis, and they started losing vision from the ethambutol. Then we had to rush and change the ATT.
Shall I conclude?
And in those 1 minute, in those situations, it's difficult to understand whether the vision loss is happening from your vitritis, uveitis, or it is happening from the ethambutol. So you have to take a call on that as well.
And there will be disproportionate vision loss compared to the lesions in the thing. And
yes.
So I think I'll come with my concluding remarks. So it goes without saying that we had a dream team for expert panel and just amazing set of speakers, one debate after the other. And imagine I sat through it and heard every bit of it. I can even relate most of your talks. So that was the kind of energy which came through. And I'm so happy that ARC saw another very successful webinar thanks to the great set of speakers. And I think I should, in all honesty, give a very special word of thanks to Dr. Avinash, because he only gave me this set of topics and this name of speakers. So some of the credit is gone away from me now, but to him, because he really richly deserves it for such a wonderful evening, which we all had. And I'm sure all our attendees would have felt the same. And of course, thanks a lot to my great co-moderator who always keeps the fire going in the webinar. And so thanks a lot, Srinivas. And I need to thank all my ARC panel who are always there in the background, always a great source of encouragement for me. Our thanks are due to the Aios team led by Mr. Kripal, who is very supportive. to Sai and Manjula from Numerotech. You have your inboxes. I hope you all have not unsubscribed me, that you must be getting mails from us. So that tells you how each of them are supportive. Our thanks are due to our webinar admin, Dr. Anand Sethi and Mr. Sharik. You can see how he closely follows up on the duration of the talk and all the mails which come to you with the links. And most importantly, our thanks are due to our sponsor, and our PG update series nowadays are sponsored by Sun Pharma, and they are truly encouraging. And probably if it goes physical, we'll have those 2-day physical meetings too, which Sun Pharma has promised us. So we look forward to greater and greater innings with all of you, great speakers. And finally, I think if we are doing well in these webinars, it's because of the kind of attendance which we've consistently got, and we look forward to it more and more, even if the physical meetings are there. Do I get a thumbs up sign that we continue webinars even after the physical meetings open up?
Yeah, sure.
Yeah, thank you so much.